Hello and welcome to clinicalpath.com. This lecture is on the anatomy and pathophysiology of the lung. So every time you think about an organ, you should have an approach to the organ. How do you think about? So for example, if I was to say, how do you think about the heart? I would say the heart is a pump with a electrical conducting system and coronary arteries that keep getting plugged. If you were to say, how do you think about the liver cleanly breaks into diseases of the hepatocyte and diseases of the biliary tree. So what's the best way to think about the lung? The lung is really best thought of as the bronchial tree versus the alveolus. And this sets up for many ways we think about it. In terms of physiology, the bronchial tree is our conducting system, whereas the alveolus is where we have gas exchange. If we talk about the pathology, diseases of the bronchial tree are obstructive diseases, but diseases of the alveolus are restrictive diseases. In the physical exam, abnormalities in the bronchial tree give me wheezing, also called rhonchi, whereas diseases in the alveolus give us crackles, also called crepitations. So that's a pretty good division that's going to work really robustly in patient care. So let's start then thinking about the bronchial tree. So remember that the lung breaks off as an embryologic bud from the GI tract and goes through about 23 divisions. Well, that's too much to handle. So we need to say, well, clinically though, how do those divisions break out? Well, here's our bronchial tree here, you can see. So let's go back and label the names so we're all in the same place and then talk about how to think about the bronchial tree. So here's my larynx. So therefore above it, that's going to be my pharynx. Trachea. And here's our first division, which is in our main stem bronchi. After that, we go through the divisions of our bronchi, which is about 2 through 7. We then come down to our non-respiratory bronchioles, and those are going to be divisions about 8 through 15. We then get down to our terminal respiratory unit, and that breaks into our respiratory bronchioles and our alveolar ducts and alveolar cells. And this is divisions then 16 through about 23. Okay, so let's talk about then the structure and function of each of these. We're going to go through histology, function, and then airflow. When we talk about the larynx, the thing to remember is that this has a squamous epithelium because the vibration necessary for phonation requires physical strength. When we come down now and look about the trachea, main stem bronchi, and bronchi, these all have in common that they have cartilage rings. And that's really important for physiology, and we're going to talk about that under function. As well, to make mucus, these have true mucus-producing glands. When we come down to the non-respiratory bronchioles, these do not have cartilage or glands, but rather have a wall with smooth muscle. And this is where all of our diseases that give us bronchospasm are going to occur. When we come down and look at the terminal respiratory unit in the respiratory bronchioles, instead of having mucus glands, in fact they have sort of a watery secretory gland called a club cell. These used to be called Clara cells, but Clara was a member of the Nazi Party, so the name has now been changed. So this then creates a watery secretion. When we come down into our alveolar structures, we now are going to pick up our type 1 pneumocytes, which are the lining cells, and our type 2 pneumocytes, which are the surfactant secreting cells. So when we come up and take a look at the function then, obviously the larynx is phonation, and when we talk about the upper respiratory tree, this is where we have our irritant and stretch receptors. as anyone who's inhaled a noxious substance is well aware. When we come down and look at our bronchi, this is going to be the area where we have maximum resistance. And the reason for that is even though the tubes are relatively large-sized, the net surface area at this level is the least, and therefore that creates the greatest amount of airflow resistance. When we take a look at our non-respiratory bronchioles, these have the largest surface area, but remember they have no cartilage, and so bronchospasm, they can cause constriction. As well, this is the start of our mucociliary sheet. When we come down and look at our non-respiratory bronchioles, this is the start of our lymphatic system. Which means when we're in our true alveolar structures, everything has to be cleared using macrophages, which have to travel a short distance then to that lymphatic tree. When we talk about how that works for airflow, we can see that the maximum velocity here is at the level of the bronchi, and that we're going to talk about when we get to forced expiration. When we come down to our non-respiratory bronchioles, this is where we're going to see our bronchospastic effects of diseases like asthma. And then when we come to our terminal respiratory unit, then this is where we see our gas exchange. So clinically then, this is how we should think of it. You should think of the larynx, trachea, and main stem bronchi. These behave as a single pathologic unit. When we talk about our bronchi, these behave as a single pathologic unit. When we talk about our non-respiratory bronchioles, these behave as a single pathologic unit. And then our terminal respiratory units, they present as a single pathologic unit. So let's take a look at what that looks like. Let's just start with our infection. The important infection that we're going to see in our laryngotracheal bronchial segment is parainfluenza virus. This is the second commonest cause of upper respiratory infection in children, and the important clinical finding is that it presents with stridor. And stridor is the sound we get when we get constriction up in that upper airway. It's a low-pitched rumbling. And when we think about why that is because we've got this infection here that's causing edema of the mucosa. And when we take a look at what that is, you can see that the maximum constriction is at the narrowest spot here. So if we are going to do just a chest x-ray, we're going to see an air bronchogram here with this shape. That's the so-called church steeple sign of croup. So when we talk about infections of the upper airway, laryngotracheal bronchitis, popularly called croup, represents parainfluenza virus and recognizable by its stridor. When we come down and take a look at the bronchial infections, our bronchial infections really are where we think of bronchopneumonias rising. So somewhere in our BC area, imagine we have a disease where we're not clearing mucus. So if you're not clearing mucus in one of these areas, and diseases that can do this are diseases that have impaired ciliary action, such as in smokers, or patients that have abnormal mucus like cystic fibrosis, or people that are just very weak and lying in bed like any of our hospital-ridden patients. And when we talk about not clearing the mucus then, obstruction leads to infection, and so we can see that obstruction leading to infection all the way down to the alveolus. So that then is going to be so-called broncho, meaning it starts with that mucus obstruction, and pneumonia because it backs up behind that poorly cleared mucus. And these are going to be relatively non-pathogenic organisms like Klebsiella, and when we take a look at what that patient's going to look like, we're going to see all these little areas of infection backed up behind those bronchial areas, so we see these patchy areas of consolidation. The next infection we want to talk about is the virus infection that we see here in the non-respiratory bronchioles with their smooth muscles but no cartilage. And so that's going to be our respiratory syncytial virus. Obviously, the DAMPs, the damage-associated molecular patterns, are going to cause edema, and so these patients present with wheezing. So the commonest cause of a lower respiratory infection in children is respiratory syncytial virus, and it presents with wheezing because we have narrowing in the bronchioles. Well, let's just come over and take a look at how useful this division is of the bronchial tree when we look at the effects of smoking. So let's just start with the cancer carcinogen effects of smoking. Think that the greater the exposure to the carcinogen, the more likely one is to develop a malignancy. So when you look at the tree and you say, which is the area that's most exposed to the malignancy, you would say to yourself, that's going to be up here in the upper airways. So this area here, somewhere between B and C. And sure enough, that's exactly where we see the malignancies, right? The carcinogenic malignancies tend to be central. When you're looking at peripheral malignancies like adenocarcinoma, they are not highly connected to smoking. The other big effect that we get of smoking is that smoking is associated with irritation. So we come down and take a look at how that irritation is going to work. Up here in the upper airways, this irritation here is going to cause mucus production. So when we talk about how this disease looks at the mucus level, right, so that's areas A and B, we see glandular hyperplasia. And that glandular hyperplasia produces the mucus that is associated with the cough of chronic bronchitis. When we come down to the bronchioles, however, we see a different pathology because there's no glands for hyperplasia. Instead, in this area, what we're going to see is we're going to see goblet cell metaplasia to produce the mucus, but the more important thing is we're going to see inflammation, and that inflammation can lead to fibrosis. So when we talk about the greatest danger of smoking that's life-threatening, it's going to be here in C because that inflammation leads to fibrosis and the life-threatening complication of bronchiolitis obliterans. So, walk through your bronchial tree, you can see each of the classic pathologies by laryngotracheal bronchial, separate from bronchioles, separate from the terminal respiratory unit. And we'll talk about the pathologies of the terminal respiratory unit in our next section when we look at the alveolus. So, remember that the key function of the lung is to bring in oxygen and dump carbon dioxide. And so when we take a look at how the alveolus is structured, everything centers on that idea. So what are the cells we have to pay attention to? Well, the lining cell, which we see here, is our type 1 pneumocyte. And it's a cell that's actually really pretty good at being thin, obviously, so that the gas exchange is easy, but it's also really good at pumping fluid out. So when you take a look at congestive heart failure, that's a cell that can absorb fluid. One of the key other functional cells is our type 2 pneumocyte. We're going to talk about this endlessly because it produces the surfactant, which is going to coat the alveolus to decrease surface tension, but this is also the progenitor cell. So this is the cell that's going to replace lost type 1 pneumocytes and then becomes the target of carcinogens for adenocarcinoma. The other cell we want to pay attention to is the endothelial cell, because any damage to that endothelial cell is going to allow leakage of the fluid for exudates. The general supporting structural cell over here is going to be our fibroblast, and we're really not going to think about this unless there's pathology, but that's going to be the cell that's going to produce all the collagen of our interstitial cell. Okay, so what are the key functions we need to pay attention to? Well, obviously the first function we've got to talk about is our alveolar capillary membrane. Remember, the whole idea is this has to be truly thin to allow easy exchange of gases. So anytime that you're talking about interstitial disease, we're talking about filling in this interstitium here between our epithelial cell and our endothelial cell. So when we talk about the alveolar capillary membrane, that's the area that's the target for our interstitial or reticular diseases. The second key function to pay attention to, of course, is the production of surfactant. That surfactant is essential for relieving the constricting or shrinking processes of our surface tension, and obviously that's going to be of really fundamental importance when we talk about our premature babies. Third thing to bear in mind, as we've discussed, is the fibrosis that comes out of pathologic stimulation of the collagen-producing cells. And then the fourth one is just one that really has to be pointed out because it's a bit odd. When we take a look at the neutrophils here, here's a neutrophil right here with its inner granules, you note that there's no circulating pool. And so what that means is all the neutrophils come through in very close contact with the endothelial cell. So anytime we see abnormalities of the neutrophils in immunologic diseases like granulomatosis with polyangiitis, we're going to see very easy activation and damage of the normal alveolar structure. Okay, well, let's take a look at some of the pathology. Let's take a look starting with our infections. Let's start with our typical, most common bacterial infection, which is going to put an encapsulated organ like pneumococcus right there in the alveolar wall. So when we talk about our infections, start with how you think about your classic lobar pneumonia. So, does that organism create a signal? Yes, it absolutely does. It's going to create a pathogen-associated molecular pattern. If it's a gram-positive, for example, that could be a teichoic acid. So that is then going to signal the resident macrophages to produce IL-1, IL-6, TNF, which is going to upregulate and dilate our endothelial cells, and that neutrophil is going to come pouring into that alveolar space. So think about your classic presentation of pneumococcus and how that pneumococcus is going to fill up the alveolar space with pus, and it's going to give us our classic consolidation, which is going to be in the lobar state. The second organism to think about is to think about our intracellular organisms. And these intracellular organisms are going to be things like obviously virus, but also organisms like chlamydia and Legionella. Well, these are not going to create pathogen-associated molecular patterns because they're intracellular. There might be a little direct damage to the epithelial cell giving you damp, but at the end of the day, these have to be adaptive immunity. And so when we think about this second group, these are going to be much slower in onset. So rather than being a disease of hours and days, these are going to be diseases of days to weeks. The other thing that's really striking about them, because this is not acute inflammatory IL-1, IL-6, TNF, these are going to present mostly with constitutional symptoms. So that's going to be aches and pains and low-grade fever and headache. And then the last important thing is these are going to have a non-productive cough because we're not seeing that formation of the alveolar pus. So when we take a look at how that's going to be with our interstitial response, because that's where the immune response is going to be taken, these are going to have a completely different X-ray pattern of a reticular interstitial disease. When we come over and talk about the purely pathologic diseases, the important image to have in your mind here is to think about the formation of transidates and exudates. So when we talk about what happens here, if we have congestive heart failure, we are really increasing the hydrostatic pressure. And we're increasing that hydrostatic pressure across an intact endothelial epithelial membrane. So when we talk about congestive heart failure, it's going to give us edema. And that edema occurs when the hydrostatic pressure is greater than about 20 millimeters of mercury. And that's really different than when we talk about an exudate, because exudates occur during situations of inflammation or tumor, and they truly cause actual damage to that barrier, which means coming out now is going to be cells and high molecular weight protein, and so that's going to be an exudate. And our classic example of that exudative diseases is going to be the diseases of acute lung injury or acute respiratory distress syndrome. So when you think about the infections and when you think about the pathology, those are the mental images we're all using to form our picture of that disease process. Having formed now a clear anatomical understanding of the lungs through the bronchial trees, four segments, and the alveolar structure, what physiology do we need of the lung? Well, there's lots of physiology to look at, but as physicians, we really want physiology that's important in the care of our patients. So if you go look in your classic physiology book, they're going to be talking about static versus dynamic physiology. Static refers to the cell that make it up into tissues and chest wall and elasticity, and dynamic refers to the airflow. And that's fine as far as it goes. But the truth of the matter is, it doesn't stick in the brain very well, and it doesn't correlate particularly well with diseases. So I think a better way of thinking about the pathophysiology of the lung is divided into inspiration, expiration, gas exchange, and then just the regulation through the chemoreceptors. So when we talk about inspiration of the lung, we really have to initiate the breath and then have the mechanical billows effect of the lung. So when we talk about what is the inspiration of the effect, all inspiration drives off the negative intrathoracic pressure of the chest wall expanding and the diaphragm pushing down. So negative intrathoracic pressure is all the work of breathing. And when we talk about how do we make that happen, remember that we're going to start with our medullary neurons. They have to do the signal that says start the inspiration. They have to get down through nerves that conduct to the skeletal muscles. That means we have to consider the neuromuscular junction. And then we have to have working muscles. And that's going to correlate with really significant pathology because the start in the medulla is where we're going to see diseases of opioid and other medication suppression. When we talk about diseases of the nerves, this is where we're going to be talking about our amyotrophic lateral sclerosis patients because they're going to die from upper motor neuron disease and ventilation or aspiration. Neuromuscular junction is going to be a problem for our myasthenia gravis patients, and then obviously disease of the skeletal muscle is going to be our muscular dystrophies, such as Duchenne muscular dystrophy. So inspiration starts with the ability of the chest wall and diaphragm to create negative intrathoracic pressure. When we talk about the work of inspiration, we're really talking now about not the chest wall so much as we're talking much more about the lung itself. And remember, the chest wall connects to the lung across the pleura. And so having a vacuum between the visceral and palatal pleura is implicit in creating that negative intrathoracic pressure to open the lungs up and create its negative pressure. When we talk about the work of inspiration, physiologists divide this into three groups. They divide this into tissue resistance, and that refers to the sliding of the pleura across each other. And in a normal pleura, this is negligible. When we talk about elastic recoil, which is often referred to by compliance, this refers to elasticity. Remember, elasticity is about a deformable structure that will return to its original shape at rest. So elastic recoil is the energy of deforming that structure. The single most important part of elastic recoil, however, is going to be surface tension. Remember that the alveolar surface is covered by a thin layer of watery fluid. And surface tension is that physicochemical property that says the water is more attracted to itself than it is to the air-fluid interface. And so what that means is if we're going to take a normal alveolus, the surface tension means it's going to naturally contract in on itself. And so the way the body deals with that is it deals with it through surfactant. Surfactant is mostly di-palmitoyl phosphatidylcholine, but it's actually a complex structure of more than probably 15 or 20 proteins and lipids. But the surfactant decreases surface tension so that it allows the opening pressures to be within physiologic limits. The last of the parameters that we use to think about the work of inspiration is airway resistance. And airway resistance refers to the friction of the flow of the air through the tubes. And it's going to be greatest in the bronchi because they have the smallest cross-sectional surface area. When we take a look at the pathophysiology of these parameters, then we can see where we need to invoke them for specific disease processes. Tissue resistance of the two rubbing pleural surfaces might be minimal physiologically, but obviously they become really significant anytime we have an acute pleuritis, because high molecular weight proteins include fibrinogen, which creates that gooey mess of an acute pleuritis and the rub that we hear, and that can then become a significant burden of work. Surfactant becomes very important in our premature infants because they can have collapsing lungs because the energy to expand against surface tension is non-physiologic. And when we talk about airway resistance, this is classically a place where we're going to talk about asthma, where we shift our narrow surface area from the bronchi to the bronchioles. Two other diseases that we talk about when we're generally talking about compliance is we can talk about an increase of compliance in emphysema. You lose so much tissue in emphysema that the lung is very easy to open and collapse. And we talk about a decrease of compliance due to the significant amount of collagen of a pulmonary fibrosis. Let's move on to expiration. Let's think about inspiration, expiration for a sec. The image that we see over here on the right is called a cat's cradle. It's a childhood game that you can play with strings in which you use the fingers to create all these geometric spaces. And it's a really good way of thinking about how the lung works, because if we think of the hand as being the chest wall, and then the string as being the way that the lung is all complexly connected to itself, we can see that when we breathe in and we pull out on the chest wall, we're literally going to pull open all of those tissues behind that negative pressure. So if I have a bronchus right here, we can appreciate that it's going to be held open because it's got this pull. And that pull of all the surrounding tissue is called radial traction. That becomes significant when we talk about the problems of expiration, not at rest, because when we just have a rest breathing tidal, the lung collapses in a very orderly fashion and these bronchioles are held open by that radial traction. The problem really becomes when we start to have forced expiration. Because when we have forced expiration, we come up against the problem of flow limitation. And this is a really important physiologic term and one that you have to know. Well, let's talk about how that works. We first start by talking about Bernoulli's principle. And what Bernoulli's principle says is that if I have a tube and I increase the flow of the fluid in it, I literally decrease the static pressure from that. So that if I have forced expiration and I'm increasing the flow of that bronchiole, there's a lack of static pressure, and so that bronchiole tends to want to collapse inward. And we can see then that that's normally prevented by radial traction. But when we get to very, very high rates, so we start getting really high rates of flow, we can exceed the capacity of the lung and it will collapse. And we're going to see that collapse mostly in our bronchioles. Because remember, they have no cartilage ring. So that cartilage ring is really important in the narrowest areas of our bronchial tree, namely the bronchi, because the cartilage holds them open against this effect of the Bernoulli rate flow phenomenon. However, when you remove that cartilage and you make the flow very rapid, as in a forced expiration, you can literally collapse the tube, and so no matter how much harder you try to force that air out, you have flow limitation because you're literally collapsing the airways. The other place this is really important to think about is it's important to think about in emphysema. Because remember, in emphysema, I lose all these alveolar structures, which means I have much less radial traction. And so that means in emphysema, my flow limitation is going to occur at much lower flows, and that leads to our air trapping. The other thing to think about in emphysema is, remember, they breathe through pursed lips. And the reason they do that is that gives them a positive end expiratory pressure, which holds their bronchioles open against the Bernoulli effect that gives them their flow limitation. So flow limitation, radial traction, Bernoulli effect is a fundamentally clinically important idea. Gas exchange is a pretty basic idea. It says that I've got an alveolar wall here, and I've got my blood here, and I have to exchange my gases. I have to blow my CO2 off, and I have to bring my oxygen in. So that's a pretty basic idea. The things we have to remember is we have to remember that saturation is complete 1/3 of the way along the alveolus. And what that means then is gas exchange is perfusion limited. It is not diffusion limited. We're not going to get diffusion limited, meaning the ability to get across this, until we see this really thick membrane of fibrosis. So most of the time, perfusion determines successful gas exchange. And the other thing to remember is that carbon dioxide diffuses at 20 times the rate of oxygen. So anytime we see a perfusion defect, we're going to see a drop of oxygen way before we see a buildup of CO2. The body's going to compensate for this diffusion defect by increasing the respiratory rate. So if everything's perfusion related, then obviously ventilation-perfusion matching is a critical function for successful gas exchange. And when we talk about that, remember that the single most important way the lung does this is it has hypoxic vasoconstriction. In any other organ that you get to, if it becomes hypoxic, you get vasodilation trying to increase the blood flow. But the lung is completely different from every other organ. When you get hypoxia locally in the lung, you get vasoconstriction so that you can maintain VQ mismatching. And the way it does is pretty straightforward. The smooth muscles in the arterioles contract anytime you have a drop in the PO2. So VQ mismatching at the local level is a functional defect. So when you hear people talking about anatomical, that's really talking about shunting at the level of the heart. VQ is functional intrapulmonary. So a couple of terms that you're going to use a lot. Whenever we have ventilation without perfusion, that's going to be the equivalent of dead space. And our model disease for that is going to be acute pulmonary embolism. When we talk about perfusion without ventilation, that's going to be shunting. And our model diseases for shunting are going to be situations with bronchial obstruction, be it by tumor or by peanut. It's going to be anytime we get consolidation. And remember, consolidation is an X-ray term that says that the alveolus is filled with a fluid. It can be a transudate or an exudate or a blood, but consolidations lead to VQ mismatching. And then the next thing we always want to talk about is if you get shunting, remember that you can compensate for CO2 by increasing ventilation. So when you increase the respiratory rate, you can clear the CO2 because it has no upper limit. The more you ventilate, the more CO2 you can exchange. However, when you get shunting, you cannot increase the O2 because the hemoglobin is 100% saturated by a third. So adding more ventilation or more oxygen is not going to improve that saturation. So the body can correct for CO2 and shunting. It cannot correct for the oxygen. And then the last thing we want to talk about is the regulation of ventilation. Remember that we talk about the body has two different sensing systems. It has the central system, in which we see the medullary neurons respond to the CSF pH. And the mental image you should have that is, remember, the brain is a sequestered area. So you always want to make sure you draw the brain with a blood-brain barrier. So over here on the pH side, pH is going to be formed by the CO2. And the CO2 can diffuse across the blood-brain barrier, so it's going to correlate with the arterial CO2. The critical fact to remember is acid does not cross the blood-brain barrier. So that if you get a metabolic acidosis, it's going to take a long time for the central system to respond to it. The central system responds to the blood CO2. In addition to the central medullary, there are also the peripheral regulatories. And the peripheral regulation occurs with chemoreceptors found both in the carotid body and in the aorta. And these structures in the peripheral chemoreceptors basically respond to CO2, they respond to the pH, and they respond to the O2. And the O2 then becomes our fail-safe mechanism so that when we have a situation in which the CO2 is normal, the O2 receptor is going to kick in when the PaO2 is less than 60 millimeters. As we'll be discussing, 60 millimeters of mercury is the definition of respiratory failure. So then that makes sense that the first of the chemoreceptors start to kick in with failure, and the signal becomes increasingly strong as the PO2 drops to a level of about 30, and then at a level of about 30, the whole system fails and you die. So when we talk about how that drive works between central, peripheral, CO2, and oxygen, the drive is really about 90% CO2 and about 10% O2 until you get into pathologic situations. So the way we care about this is we care about this clinical problem, the use of oxygen in COPD. So this is one of the really important clinical stories you've got to be able to discuss the pathophysiology of. So remember, we're talking about situations in which we get acute exacerbations. And these are commonly just superimposed infections, either bronchopneumonia or viral. And with the acute exacerbations in COPD, the patients go into respiratory failure. And remember, the definition of respiratory failure is when the oxygen is less than 60 millimeters of mercury. And in this situation, you're going to give nasal O2. Now pay attention, many of your older books are going to say this can lead to further failure because it suppresses the stimulation of the peripheral chemoreceptors that are given all the drive. And that is wrong. So wherever book you read that in, that is not true. When you give the O2, you still will see a little tiny decrease in ventilatory rate, but that restores in minutes. However, if you follow these patients, you will see a rise in their CO2. So the question is, if that rise in the CO2 is not due to hypoventilation, what is it due to? And the answer is about 75% of that rise in the PCO2 is due to VQ mismatching. And this goes back to the idea that vasoconstriction occurs in hypoxia. Because what you're doing in these patients is, without improving their ventilation, you're increasing the alveolar O2. And so that is causing vasodilation. Well, vasodilation is increasing flow without increasing ventilation, and that's going to give you an increase in shunting. And that's going to give you the rise then of the PCO2 without giving you an improvement in the O2. And about 25% of that rise in CO2 is due to the Haldane effect. And when we talk about the Haldane effect, that describes the fact that much of your CO2 is carried on your hemoglobin, your so-called carboxyhemoglobin. Well, O2 has a higher avidity, so when the O2 comes in, it displaces the CO2 into the blood, and you can see that rise. So what are you supposed to do then when you have COPD and respiratory failure? You will certainly give oxygen. Anytime someone's in respiratory failure, you're going to try to keep that hypoxia above failure limits. The trick is you can't overdo it, or the oxygen causes such rearranging of the VOQ mismatching and so much Haldane effect, you get toxic levels of CO2. So you give the oxygen, but you use your pulse oximetry to keep the saturation somewhere between 89 to 91%, because that's right at the proper place that we need it for in our oxygen binding curve. There's our 90% saturation, and that corresponds to about 60 millimeters of mercury O2, which is about where we want to be while minimizing the hypercapnia. So that brings us to the end of our discussion. Let's just summarize what you should be able to do after this discussion. You should be able to discuss the bronchial tree, its 4 areas, and how we think of that pathologically and why their histology correlates to that function. You should be able to talk about the alveolar wall and the type 1 and type 2 pneumocytes, surfactant, the intimate relationship of the endothelial cell to the epithelial cell, and the fact that this is how we think of our transidates and exudates of edema. In terms of our pathophysiology, we want to be able to talk about inspiration, and we want to talk about our tissue resistance, elastic recoil and surface tension, and airway resistance. When we talk about expiration, we want to be able to talk about flow limitation with forced expiration. When we talk about our gas exchange, we want to be able to talk about perfusion limited and the fact that CO2 is 20 times the rate of oxygen. We want to be able to talk about VQ matching and the fact that hypoxia causes vasoconstriction to try to maintain that normal ratio. We want to talk about how mismatching is seen most commonly with shunting in consolidations. And the last thing we want to be able to do is we want to be able to talk about the regulation of ventilation and be able to discuss the specific instance of giving oxygen to patients with COPD in acute failure. That brings us to the end of this talk.